Good morning. Thank you so much for joining Forge Breast Cancer Survivor Center's Coffee Conversations. We're so excited today to have Dr. Littleton here with us, especially during Breast Cancer Awareness Month. And he is going to talk with us about breast cancer awareness and screenings. So really excited to have him here. Dr. Littleton, if you could go ahead and give us a little introduction about yourself.
Sure. Well, first, thank you for having me. My name is Michael Littleton. I work over at Brookwood Medical Center. But a large part of my practice is breast disease and breast cancer. And I grew up here in Birmingham and went to UAB Med School and trained at UAB. And I was real fortunate down there to train under some guys, Kirby Bland and Marshall Urist, who really did a lot with breast disease and breast cancer. So I was very fortunate that they were there. I came over here to Brookwood. I've been over here 18 years, and I had some great mentors and guys, Chuck Shoemate and Rick Kirkland, who had really developed a good breast care program here at Brookwood. And I was fortunate for them to continue to mentor me. And again, that's probably 3/4 of my practice now. I really enjoy it. The only other thing I'll say is that my father was an OB/GYN here at Brookwood for 37 years, started back in the 70s. He's retired now and in his early 80s, but doing well. And so women's health is just kind of something that I grew up with, and it's that I'm passionate about. So
That is so cool. Your dad to be a doctor and then you're a doctor. Like, that's a cool thing.
yeah,
I'm sure he's proud.
yeah.
And so, like I said earlier, we're talking about breast cancer awareness and screenings, right? And some people don't know what a mammogram is. They don't know when they should get one or why it's important. So could you kind of tell everybody, like, what is a mammogram and why is that so important for women's health?
Sure. So mammograms are the primary screening modality for breast cancer. And it is think of it almost like an x-ray, but the breast is in compression. And that's one of the things that women don't like about it, is the compression, because it can be uncomfortable. But typically women will get their screening mammogram at age 35. And if that looks good, then they'll jump to age 40. And then from 40, typically do it every year after that. I tell women a lot of times in the office when I'm having conversations, it's like us getting our colonoscopies. It's like us guys getting their a PSA check for prostate. It's just real important to, if you're gonna develop a breast cancer, perhaps, let's catch it at a very early stage. And that's why the screening is so important.
Thank you so much. And kind of talking about, I like that you broke down the different ages, right? And I bring that up because we are seeing younger women get diagnosed with breast cancer. So I know this is kind of off, to the side a little bit as it relates to what we kind of previously discussed, but, would a person need to be screened earlier based on their risk? Like if their mother or their father or grandmother or whomever had breast cancer or prostate, colon, would they need to keep that in mind when they're thinking about, okay, I need to start getting mammograms and screenings early?
Perhaps they should, yes, and that's an excellent point. So what I do with people like that is I send them to our genetic counselor, Stacy, in the cancer center, and that doesn't have to be here at Brookwood. Most hospitals have somebody like that. But I think it's real important that, and this kind of segues into genetic testing a little bit. Some women would qualify for genetic testing based on their family history. Maybe they don't need genetic testing, but nevertheless, they need to discuss their family history, and perhaps they do adhere to a different screening regimen than the general public, if you will. And I just from a standpoint of how I go about that, I really like Stacy or someone like her to guide that a little bit. Honestly, it helps us with documentation as far as insurance companies covering the test and all that kind of stuff. So absolutely, the big picture answer to your question is, yeah, if a first degree relative, your mother, your sister, had breast cancer at an early age, that certainly may put you in another category than someone who has a distant relative or no breast cancer history in their family at all.
Thank you. So when someone has been screened for breast cancer, so they've done that first step, but then they're informed that they'll need to come in and do a biopsy. Can you kind of tell us about what does that mean? What is a biopsy, and what does that process look like?
Yeah, so women will present for a biopsy, say they feel a palpable mass, and they typically will go for a mammogram and ultrasound, but nevertheless they felt something, or a physician has felt something, or they can't feel anything, nor can a physician, but they go for a mammogram and there's something found, and they further evaluate it with ultrasound, perhaps, but then they've got an abnormality, typically a category 4 finding, which means they need a biopsy. Now, the main way we do biopsies are what are called core needle biopsies or stereotactic biopsies. So it's not an operation. It is a 5-minute procedure, either under mammogram guidance or under ultrasound guidance. Those are the main ways. You can do them under MRI guidance as well. But we use mammogram to get to this spot, to know where we're going to, ultrasound to get to where we're going to. And then we numb the patient up. We make a little, very small incision, run a little biopsy tool in, biopsy the area, drop a little clip in to mark where we biopsied. The whole thing takes 5 minutes. The only part that bothers the patient is the numbing medicine. The biggest kind of thing they run into afterwards is maybe some bruising. And that's how we not only diagnose most of our cancers, but also that's how most women, their breast abnormalities that are seen on mammogram and ultrasound come back okay. So most women, I tell you, the results come back fine. They have that 5-minute procedure and they're done.
That's good to know, right? Because I've had family members who've needed to have biopsies done, and their immediate jump is like, oh my gosh, I have breast cancer. So it's nice to know, like, okay, well, even if there's something that pops up, it doesn't necessarily mean that you'll have breast cancer.
Absolutely. And I honestly, I tell people 85 to 90% of these biopsies I do, and I bet we do 8 to 10 of these every week, come back benign. So statistically, these things are going to be benign. But if it is something, we want to catch it at an early stage or spot, if you will.
So in the event that someone has a biopsy and it does come back that it's not benign, what are the next steps from following that? So they've had the biopsy and the biopsy came back, okay, like this is a cancer of some kind. What do those conversations and steps look like for someone?
So typically they would sit down with a physician within the next day or two. So typically we can get those biopsies turned around in 24, 48 hours. And if it's a cancer, I try to sit down with them right away within a day or so, because the sooner we can kind of talk and I can educate them on things, the better they're going to feel about, hey, we've got a plan moving forward. This is what all of this means and so forth. But sometimes people have biopsies that are done, say, by a radiologist. And so then they need to be set up with a surgeon. Typically, that's where it starts. Not always. Some people will be set up with a medical oncologist and then work their way to the surgeon. But they need to basically take that positive biopsy and then sit down with a physician who manages breast cancer and start getting information.
So it sounds very individualized, right? So I think it depends on the kind of cancer, is what I'm hearing, that you will find as relates to what your first step is, aside from, okay, we sit down and we have a conversation.
To sit down and have a conversation, but it's different as to different routes. Like I'll get some patients sent to me from a medical oncologist who they had an abnormal mammogram, it was biopsied somewhere, sent to a medical oncologist because perhaps that person took care of a family member, and then they get sent to me. Most of these women will eventually meet a surgeon, a medical oncologist, and a radiation oncologist. They don't always need radiation, but at least a surgeon and a medical oncologist. So most women will start with the surgeon because that's the way the biopsy was kind of facilitated, but not always. But eventually they just need to get in front of a physician and say, all right, where do I go with this?
Are there any misconceptions about um, getting a mammogram or screenings, and what does that need to? What are some things that you hear that you're just like, gosh, I wish you knew the real about this and what this process is like, and what it looks like in real life? Because I mean, we can read things online and we can see things in video, but it's different when it's real. So, what are some things that you think the community would benefit from knowing more about mammograms and screenings in real time?
Excellent question, because I think the key is to get to women to get their mammograms or get their biopsies done, and again catch stuff at an early stage. And so, two things that come to mind with that question. One is the biopsies. Sometimes we hear that number one, the biopsy is not done in the operating room. 95+% of the time, it's just a 5-minute procedure. Number two, we hear actually sometimes that, hey, if you're going to do a biopsy of it, doesn't it kind of allow the cancer to kind of grow? Does it allow it to get oxygen to it and it spreads? And that's just a misconception. It does not. I'd tell you that 90% of the breast cancers, if not more, that we diagnosed are done with a core needle biopsy. And there's no downside to that at all. In fact, there's very much an upside that we diagnose it with a core biopsy and then tend to go to the operating room one time versus two. I think that's the main thing that comes to mind as far as misconceptions.
Thank you. And I'm glad that you pointed that out because I honestly thought that biopsies were a surgical procedure. So it's nice to know that like it's not as invasive to your body as you would think it is.
You're right. And we do, so if it's an ultrasound finding, we do some of those here in the office. If it's a mammogram finding, we walk across the street to the Women's Diagnostic Center and do it on a mammogram guidance. But it truly is a 5-minute procedure to target the area, clean the skin with some alcohol, numb them up with lidocaine, which just is a few seconds of discomfort, and then that's it. Little incision, kind of maybe a 1/4 inch incision, and then do the biopsy, and then put a clip in to mark where we were, close it with stereo strips, and the whole thing takes 5 minutes. Women are usually very pleasantly surprised. Maybe that's another misconception that we could, put to rest. They're always pleasantly surprised as to, gosh, that's all there was to it. That was easier than I thought. So,
Yeah. It certainly sounds like it because in my mind, like I said, even though I work in breast cancer, I mean, I'm always learning new things about just how things really work. And some people might speak to an experience that they've had 30 years ago versus it's very different now. And so I think that that's really fortunate for us that we're able to kind of talk with you to kind of clear up that process or just some misconceptions that people might have. Um, Another question that I have for you today is what are some things that you think would be helpful for someone who has a breast cancer or a mammogram screening coming up, but they're nervous about it? They don't know much about breast cancer. They don't really know, what ways to prepare, whether that's physically or mentally. What are some things that you would suggest for someone who wants to, stay on top of their health, especially as they're learning? I mean, unfortunately, people don't always know that, hey, my aunt had breast cancer, or,
yeah.
some people are just very private about their diagnosis. So it can be overwhelming for someone who's like, oh my gosh, I'm related to someone who has breast cancer. My mammogram is coming up. Like, what are some things that you would suggest for individuals who are preparing for this?
Yeah. I think the main thing is you got to keep in mind kind of, okay, what age am I? Do I need to be getting my mammograms? And like we said earlier, typically one at 35 and then jump to 40 and yearly thereafter. Again, different if you've got a strong family history of breast cancer. I think really simply to go get your mammogram, and that sounds very simple, but a lot of people kind of just like we all do, we put stuff off that doesn't sound very fun, and and I liken it to colon cancer screening a little bit, and or just people going to the physician yearly to keep an eye on their blood pressure, and then over time things kind of compound, and then people get to where they're like, gosh, I hadn't been in 2 or 3 years to get my mammogram, and I'm almost embarrassed to go. It's been so long. I'm afraid they're going to kind of get on me as to how long, why haven't you been here every year? And that's, don't think about it like that. They are there to get your mammogram done and get a read. And again, most of them come back fine, and then you've got that off your back. You've got kind of a clean slate. And you don't have to worry about it. But it is kind of one of these things where you just have to kind of push yourself to say, I really need to get this done, so that nothing creeps up on me. I tell women, sometimes we don't want to ideally find a mass when we can feel it, because all too often then it's still very treatable, but it can be a much bigger to do. So I hope that helps some.
It does. Thank you so much, Dr. Littleton, today, for carving out the time to talk with us and to just kind of lay it out and lay it out so plainly. I always appreciate when doctors are able to speak English to us, because it can seem overwhelming, when you're thinking about anything medical, but then you throw in the terminology. Sometimes that can be intimidating. So I'm always just very grateful when we have a professional who's able to explain something so plainly for us, and also educating us on the things that we need to know. So thank you so much for that. And thank you for joining our coffee conversation.
Absolutely. Thank you for having me.